Good afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on regional harm reduction snapshots in Ontario and the impact of COVID-19, presenting findings from the 2022 to 23 LDCP. My name is Pamela Leese, and I'm a public health physician in the Health Promotion, Chronic Disease and Injury Prevention Department at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin, I'd like to mention some housekeeping items. The chat pod is disabled to limit any distractions during the presentation. You can use the Q&A pod if you have questions throughout the session. Discussion and answer period will follow the presentation with the panelists. And if any point in the session you experience technical issues, please email capacitybuilding@oahpp.ca. The slides from the presentation and a recording will be available on the events page about 2 weeks after the live session. And I'd like to state as the moderator for the session that I don't have conflicts of interest to disclose. So for introducing our panelists for today, it's my pleasure to welcome Emma Nagy, Dr. Tara Gomes, and Jess Bashara. Emma Nagy is the Research Associate at Kingston, Frontenac, and Lennox and Addington Public Health, KFLA Public Health, and Dr. Tara Gomes is the Program Director of the Ontario Drug Policy Research Network and Scientific Director of Urban and Community Health at Unity Health Toronto. And Jess Bashara is a member from the ODPRN Lived Experience Advisory Group. So first I'll pass it to Emma, and thanks everyone for joining.
Thank you so much, Pam. On behalf of the locally driven collaborative project group that I'll refer to as the LDCP group today, thank you so much for having us and for being here today. We're so pleased to be able to introduce you to the Regional Harm Reduction Snapshot tool. And next slide, please. During the session today, we want to share some of the contextual landscape that led so many of us to work together over the past several months. We'll show you the snapshot tool that we created to help build situational awareness related to harm reduction in Ontario, go over some of the findings with you, and then most importantly, have a discussion around use and the implications of the data as we plan for the future. Next slide, please. So I'd first like to acknowledge that our work for this project took place on traditional Indigenous territories across Ontario. The impact of colonialism on the health of First Nations, Métis, and Inuit people has led to a greater burden of opioid toxicity harms in Indigenous people. Indigenous communities across Ontario are beautifully diverse, and their unique perspectives, solutions, and expertise are needed to best plan for the future. The project group would also like to recognize the individuals represented in this data, many of whom have sadly lost their lives and been harmed by the opioid crisis. These individuals and their families are the impetus for the harm reduction work we do and our goal to do better as a health system. Next slide, please. I'm going to now hand it over to Tara to talk about the contextual landscape that led to this research project.
Thank you, Emma, and thanks for having us today. Really pleased to be able to share some of the collaborative work that we've been undertaking for the last little while. So what I wanted to do is just start by giving a bit of a lay of the land in terms of the opioid toxicity crisis that we have in Ontario, and specifically how things have shifted during the pandemic. That really, as Emma mentioned, led to us coming together to develop this dashboard, and hopefully we'll also give an idea of how we came to the combination of indicators that are on that dashboard. So I often start with this figure because I think it's helpful to look at the history of opioid toxicities across Ontario. This is the number of opioid-related deaths in Ontario since 1991. And we can see that around 2000, the rate and number of deaths began to increase in the province. And we were concerned about that. But then in 2016, things started to accelerate even more as we saw fentanyl really enter the unregulated drug supply here in the province. And we were in a position, through to 2019, where there was a lot of concern about this immense increase in opioid-related harm and how to respond to this. And then what happened was the COVID-19 pandemic arrived, and we again saw what seemed like an almost hard to imagine increase immediately as the pandemic arrived in Ontario, with enormous loss of life from opioid toxicities that we saw, and that continues to this day. We've seen some plateauing in more recent months, but we continue to see these extremely elevated rates of opioid toxicity deaths across the province. And we know there are a lot of different factors that are tied to this. We know that there were shifts in the drug supply, what was in the drug supply and how people accessed it. We also know that pandemic-related measures changed people's access to community-based services that they relied on to stay safe, harm reduction programs and other community supports, as well as interruptions in access to healthcare providers, which can impact your ability to access treatment for an opioid use disorder or for other healthcare needs that people have. And then, of course, there was this focus on physical or social distancing to help prevent the spread of COVID-19, which, while effective at that, can actually lead to very risky situations for people who use drugs if they weren't able to rely on having others around to respond in case of an overdose. So, we really know that all of this came together to create a really risky period for people who use drugs in terms of unpredictable drug supplies, less access to services, and having less people around to be able to respond when overdoses occurred. And so what we've been doing over the past several years is using the information that we have to try and better understand some of these various factors and really to think about what the effective responses should be. And so some of what I'm going to review right now is really helping us, is aligned with these three ideas of helping us think about where geographically as well as situationally these toxicity events are happening, what kinds of services are needed based on the types of information that we can understand from opioid-related harms in Ontario, and where should these services be provided. So if we think about where opioid toxicity events are happening, they are primarily occurring within private residences about 3/4 of the time. And I think that's important because it speaks to the fact that a lot of the time, harm reduction measures, having people around, having naloxone on hand, these are all important factors that can help prevent these deaths, as well as providing access to treatment for people who are open to that and who have an opioid use disorder. But one of the other things that we have seen during the pandemic is there has been a shift towards more fatal overdoses happening outdoors and in shelters and other supportive living spaces. And that's really important as we think about what are the services we can think about regionally to help meet the needs of people who are experiencing harm in these other locations as well. And this ties in with information we have around the living arrangement and the disproportionate impacts of the pandemic on people who are experiencing homelessness. During the pandemic, 1 out of every 6 opioid toxicity events that happened occurred among somebody who was experiencing homelessness at the time. And importantly, a lot of the time, these overdoses happened within shelters or within hotels that were set up as emergency shelter services throughout the pandemic. And so this has really identified this, not only this population that is being disproportionately impacted and we need to make sure we're providing services to, but also thinking about how we provide those services within shelters and other supportive living spaces to make sure that they're meeting the needs of the people who we are serving. But it's also really important not only to understand where the toxicities are occurring, but what is driving them and what are the substances that are really influencing these trends. I think it will come as a surprise to nobody that the vast majority of opioid toxicity deaths that happen now in Ontario are being driven by fentanyl, which is in the unregulated drug supply. About 90% of opioid-related deaths had fentanyl as direct contributors throughout the pandemic. And when pharmaceutical or prescription opioids are present, it is quite often methadone that is present, which is a medication that is used to treat an opioid use disorder. So we know that this is primarily an issue of the unregulated drug supply, and one that requires responses to that as being the source of a lot of the harm that people are experiencing. But we also have to remember that this is not a crisis of people using opioids alone, and that there are a lot of other factors that play a role in this. One of the really important things that we've seen change during the pandemic is benzodiazepine, which entered the fentanyl drug supply. So about half of opioid toxicity deaths that occurred during the pandemic had benzodiazepines detected. which we know are highly sedating, complicate the overdose response, and also increase people's risk when taking opioids and benzodiazepines together. But this was a situation of drugs like atizolame entering the fentanyl drug supply. And so people who are accessing fentanyl were inadvertently also being exposed to large amounts of sedating benzodiazepines. And what we've then seen as well is this increase in stimulant involvement in deaths. And there are a number of factors we can discuss later about why this may have happened. But one element of this is also people trying to address the sedating effects of the benzodiazepines in the drug supply by using cocaine or methamphetamines as a stimulant to try and counteract those effects, which I just say just to help everybody connect the dots to the fact that when the unregulated drug supply is really unpredictable, people have to adapt. And sometimes that adaptation means using other substances which increase your risk, but are required in order to address the unpredictability of the drug supply that you're accessing. We also can see that there have been shifts in the ways in which people are using drugs. And this started before the pandemic, but has continued towards more inhalation and movements away from injection drug use. And this is important because, we have needle exchange programs in the province. We also have many public health programs that provide other harm reduction supplies. And it's really important to think about how we change and scale up the availability of different harm reduction supplies in response to the shifts in the ways that people are using drugs. And so if there's more inhalation, and if that is particularly the case within certain parts of the province, we need to think about how we make sure that there are more harm reduction supplies that help support people safely inhale drugs in those parts of the province. And talking about geography, we also have to think about where we distribute supplies based on where the most harm is occurring. We know that a lot of the large absolute numbers of opioid-related harms happen in large urban centers, but we also know that when you adjust for the population, Northern Ontario has a much higher rate of opioid-related deaths and other opioid-related harms compared to Southern Ontario, and that has more than doubled during the pandemic. And then when we break this down even further by public health unit, we see even more diversity. And so what I think this figure really shows is that there's no part of the province that is untouched by opioid-related harms, but the degree to which opioid-related harms are occurring does vary quite dramatically across the province. It has increased in every health unit throughout the pandemic, but to different degrees. And so we need to make sure that we are tailoring our responses at the local level to the needs of those populations. And we also need to make sure we're tailoring it to the actual underlying needs of people who are using drugs. So we do know that about 2/3 of people during the pandemic who experienced a fatal overdose had an opioid use disorder diagnosis, which means that they may have benefited from accessing treatment like methadone or buprenorphine products. It's important to note that means about 1/3 of people did not have an opioid use disorder diagnosis. They are not going to be eligible or benefit from treatment, and so likely need other services like harm reduction and other community-based programs to help keep them safe and to make sure that they have safe supplies of drugs and predictable supplies. But among those who have an opioid use disorder, we know that there can be benefit from first-line treatment like methadone and buprenorphine. But when we look at recent engagement with treatment, it is incredibly low. Even in the past 5 years, only 1/3 of people have accessed treatment. And so this ties in with the fact that not only do we need to consider harm reduction, we need to think about treatment and how do we create treatment programs that are accessible, but also that meet the needs of people who are looking for them, that they don't necessarily have to go to the pharmacy every day, that the doses that are provided are sufficient to meet the needs of people who have been exposed to a lot of fentanyl in the unregulated supply. And when we think about where we place these services, I've talked about harm reduction, supplies, naloxone, community-based programs, treatment. All of these are services that are going to be clearly needed, and there's going to have to be a multi-pronged approach. And many people on this call, I'm sure, are actively engaged in implementing those multi-pronged approaches right now. But one of the things that a lot of people discuss is the fact that there's a concern that this is a population that is very disenfranchised from the healthcare system and is not accessing the healthcare system and is very hard to reach. And while in many ways, because of the discrimination that they have experienced, that is true, when we look at recent engagement in the healthcare system among people with a fatal overdose, about 1/4 had some engagement in the last week before death. And that is usually a combination of emergency department visits and outpatient visits. So there is actually quite a high degree of interaction and engagement with the healthcare system among people at high risk of opioid-related death. And we need to think about how we can better integrate these programs and services directly into these settings to make sure that they're accessible and that people are connected to the services and programs that they need. So this is just an attempt to kind of pull it all together to say that, what we know and how we came to developing this dashboard was really based on the fact that we need to think about rapidly mobilizing responses that address the volatile drug supply and the fact that more people are using multiple substances, and how that can contribute to harm and the kinds of services that are needed. We also need to make sure that those services are broad and cover both treatment and harm reduction options, and that those responses also address the changing patterns of substance use that people have, the tolerances that they have to based on the fentanyl drug supply, the benzodiazepines that they have been exposed to, and the fact that there's more inhalation, and that all of these services have to be more integrated throughout our healthcare system. So this is really what then led us to come together and say, how can we pull data together to really help inform local action on this issue, to figure out what the right combination of services and programs are that can meet the needs at individual community levels, which led us to this work that Emma is now going to walk us through. So I'm going to pass it back to you, Emma, to take us through the next few slides.
Thank you, Tara. Yes, so there are so many organizations, networks, individuals working together across the province to address the opioid toxicity crisis. So when Public Health did that call out for our LDCP project, several groups were inspired to come together and work on this joint initiative. Next slide, please. So here you can see our LDCP project members in the table to the right, and it shows the core project team and also the knowledge user and advisor teams as well. And the map is a visual to show you which public health units participated in this project, and the organizations in blue font in the table represent groups that include a provincial level perspective. So for example, ODPRN's lived experience advisory group participated in this project and provided expertise and input at key project milestones, and League includes representation from individuals from across the province. Many more public health units were actually interested, so I want to mention that as well, but they didn't quite have the capacity at the time to participate in this particular LDCP, but I know they wanted to hear the findings and stay in touch, so we are excited to be able to present them to you today. So next slide, please. The collaborative project together had two main objectives. The first was, how has harm reduction service delivery changed within each public health unit region in Ontario, and looking at the time span that began before the pandemic. So we actually went back to 2016. And the second is, what is the relationship of these changes to opioid-related morbidity and mortality over the course of the COVID-19 pandemic? Next slide, please. To address the objectives, we created regional snapshots that displayed some key indicators over the past few years, including data points from before the pandemic onset to be able to look at those trends over time. And we included data from two main data sources to build the snapshots. The first was the Ontario Opioid Indicator Tool by ODPRN, and the second is the Interactive Opioid Tool by Public Health Ontario. And throughout the process, the group underwent a prioritization process to ultimately decide on the indicators that went into the snapshots. And the group decided on needles provided, naloxone doses provided, foils provided, individuals dispensed OAT as the service delivery indicators, and emergency department visits and deaths due to opioid toxicity were included as health-related indicators. Next slide, please. So now I will take over the screen and share the snapshots with you. Okay, so here are the harm reduction opioid harm snapshots, and they are found on the ODPRN website. I'll make it a bit smaller. Oh, hang on. Now it's probably too small. How does that look? Good. Okay, great. There is a how-to video, so when you're sharing this with partners or other individuals, feel free to point them to that video. It does give a demo of how this tool works, but of course I'll be doing the live version for you today. When you first land on the snapshots, you'll be taken to this introductory page. And this page displays data on the key indicators and a visual as well of the changes over time you can see in the middle column. You can select Ontario in the right-hand side at the top right, or you can drill down to select your specific health unit region to look at the key metrics in your area. On this page, we've also included some of the key definitions that you'll see inside the main snapshot page. So to explore the data further, go to the main page. And on this main page, as well as the visuals you just saw on the intro page in just slightly different locations, you'll also find here comparisons to Ontario. Oh, sorry. Comparisons to Ontario, and also, I'm just seeing, there we go. Comparisons to Ontario and also to other public health units across the province. For each of the public health unit regions, we used a quintile ranking system where we divided all the 34 health unit regions into 5 groups. So you can see where your region is related to others in the province. And we have such a diverse province, of course, with different needs in different areas. So we hope you use this particular feature to support situational awareness and also your advocacy efforts in your region. On this page, you'll also see the type of opioid present at death and trends by age and sex for ED visits and deaths. And, you know, this is really worth looking at more closely according to region, because we did see some variations across regions related to age and sex, for example, for ED visits and deaths. Okay, so let's look at the data in a different way. Here you'll see that regions with darker shades indicate that rates are higher for that indicator in that area. You can also press play up here in the top right, and you can see the trends change over time. For foils, we had data from 2019 onward, and that's why it looks gray at the beginning. You can also zoom in to smaller regions if you like. So you'll see at the top it says zoom to region, and that's helpful especially for Southern Ontario, where it's a bit trickier to see zoomed out like this what exactly is going on in each region. And then this trends page, this lets you see each indicator across all of the public health units in one place. So I'm going to choose needles provided just for a little bit of an activity and to let you have a chance to use the tool as well. So I'm going to look more closely at KFLNA just because that's the region that I'm from, that I'm calling in from. So the purple arrows in this specific case mean that there are ongoing trends from 2018 to 2021 and require each year to show consecutive patterns to indicate an increase or a decrease. So in the case of KFLNA, rates consecutively decreased between 2018 and 2021, and that's why you're seeing the downward purple arrow on that particular graph. The golden arrows represent a change just between 2020 and 2021. So we wanted to look at that difference starting at pandemic onset and the following year. And they represent a change of 10% or greater. So in this case, the downward golden arrow in KFLNA shows that needle provision decreased by 10% or greater between 2020 and 2021. So now I would like you to find your public health unit region and just make a mental note of what the line graph is showing in your specific area. And as you look at it, you can see if things seem to shift since the pandemic onset by looking at the gold symbol. If you see a squiggly line in the two squiggly lines in your region, it just means that things have stayed relatively the same. So the LDCP group noticed some broader findings through this work, and we wanted to share them with you. So next slide, please. 2016, when looking at some of the overall trends, we found ED visits and deaths related to opioid toxicity in Ontario have increased, ED visits and deaths. There are some nuances, though, related to changes in harm reduction service delivery indicators. So what we found was the data shows that naloxone and foils provided have increased in most regions. OAT rates have remained similar or seen slight increases across some regions. And as we saw, there was variation in terms of needles provided and the trends related to that particular indicator. Next slide, please. Then when just looking at the difference between 2020 and 2021, when looking at Ontario as a whole, we found, even within the shorter time period, we found those trends were similar at the Ontario level. There was some variation between health units, with some remaining similar between those 2 years. Some indicators rates increased and others decreased by 10% or more. So that's what you're seeing in this table is the number that have increased by 10% or greater, the number that have decreased by 10% or greater, and the number that have stayed the same. Next slide, please. And, you know, because there are regional differences, findings indicate that a regional approach is really beneficial, and considering the unique needs and the unique trends that have been observed across the province, the findings indicate that there's a need for comprehensive services, and it may be highest in Northern Health Unit regions, especially, for example, in Thunder Bay, where the highest death rates were observed, in Sudbury, where the highest ED visit rates were observed. And this is notable because some of the Northern Health Unit regions also have the highest rates of individuals on OAT, the highest rates of naloxone doses provided, needles provided, and foils provided, as you can see in terms of the shading in these maps. And health impact could demonstrate that more support is needed. And again, the findings are most meaningful when done, when communicated within your community. So you know the situation and your needs best, and we hope that the data shared in this way can be helpful for you and your partners. Next slide, please. So of course there are some limitations, you know, with any project, and this one is no exception, to consider when using the snapshots and interpreting the findings. Firstly, the data used cannot provide a complete understanding of all service components that have shifted related to harm reduction service delivery in Ontario over the past few years. And the project's findings are not inclusive of all harm reduction supports delivered in each region. A lot of that actually came down to even the practicality of space and being able to, you know, create something that was visually friendly, and that's why we went through the prioritization process. The tool, again, is meant to be one piece of evidence that sits within a broader evidence base, including the contextual information that you and your partners bring to the table to use towards our goal of improving health in our province. Next slide, please. Great. So now I would like to hand it over to Jess, who is going to share about community changes, regional data, and the usefulness of this tool.
Thank you. So it was actually pretty cool to get to participate with the Lived Experience Advisory Group, and then kind of watch the tool develop and then get to use it myself. I've just wrapped up a SUAP grant, and we are applying for some other grants right now, so it was neat to be able to use the information there. I just kind of want to talk about some of the things that I found out that I wasn't really expecting to find out. And the first one I noticed is when I was using like the trends page, and it's like particularly in 2019, our naloxone was way up and our deaths were way down. And after that year, I kind of changed my direction from myself handing out the naloxone and talking to people to training community partners and trying to get naloxone available from different agencies. And I thought that it would increase the naloxone that was given out, but and not that I was the only one giving it out, but it really didn't. And I think to me, it just shows how people are a lot more comfortable working with peers. And where my office was, it was away from everybody else. So like I work in a methadone clinic, and you can get methadone like up at the window when you're getting your dose or talking to the girls. And some people do, but the majority of people were coming to me and they were talking about stuff that was going on. Like it gave us a reason to connect as well. So it really shocked me. I thought that focusing on getting other agencies and naloxone available in lots of other places would be more helpful, but I'm not so sure that it was at this point. The other thing that I noticed was our individuals on OAT have gone up compared to the rest of the province. And I believe, so the city that I live in, especially, and really throughout our health unit district, there's not a lot of resources available for people who use substances. A lot of agencies take an abstinence approach, which just really doesn't work for a lot of people. And we are lucky enough at our OAT clinics to have caseworkers and counselors from our addictions and mental health agency working out of there at a really low barrier. Like it was a walk-in, you didn't need to make appointments. And I think that a lot of people had kind of joined the clinic because they wanted to have access to those services because, if they went to the mental health agency, it was 6 to 8 month wait, and people just don't want to wait that long. They really can't wait that long in these days. So to see that people, well, I'm assuming I shouldn't say for sure, but I really I talked to some people and they agreed, like clients and my peers. But to see that people are willing to get on to, methadone or Suboxone just to have access to services, I think is big. I think we need to change the way that the agencies I work with are having services available, because OAT isn't always the best. Like it's helpful for some people, but for some people it becomes like something that they have to, something else that they have to maintain every day. And it becomes kind of a burden, but that people are willing to get on the program just to have access to services is mind-blowing to me. And really that's about it. Thank you. And I'm going to pass it back to Emma.
Thank you so much, Jess. It's so helpful to hear your perspective and, really ground some of the numbers that we have been looking at, and just to also, zoom in on a specific region and hear how you interpreted the data and just some of the changes that you observed, and also some of the shortcomings that exist. So thank you so much for coming here and sharing with all of us today. So to everyone here today, you are invited to share the snapshots, and a report that is a bit more fulsome is going to be added to the ODPRN website as well as an infographic actually to highlight some of the findings. And you're welcome to share all of these resources with your organizations, with your colleagues, with your networks, with anyone really who you think would be interested in seeing these findings. And you're invited, of course, to use these findings, use it as one of the bodies of evidence for advocacy and to enhance situational awareness in your region. the LDCP group, although our project is, technically finished, we still are working on a few things together and are carrying the momentum forward of this collaborative work. So we have a Masters of Public Health project on the go right now over the summer, where we'll be looking a little bit more into the innovations in service delivery that we observed over the past few years, because, although a lot of the changes were, negative over the past few years, within public health unit regions, there were some innovations that happened as well. So we're going to look a bit more closely at that to see if there are any lessons learned there that we can share together across the province, and use that to also help us with planning. We also will be presenting these findings at the Canadian Centre for Substance Abuse conference in November in 2023. So if anyone is heading to that, I will probably see you there. And next slide, please. So we'll be moving into the final question period in a moment. I think capacity building, please share in the chat. Thank you. Everyone's contact information. So thank you so much. And I'm going to pass this back to Pam for the Q&A.
Great. Thanks so much for sharing all this wonderful work. To Emma, Tara, and Jess. And so we're moving to the Q&A segment. I have seen a couple of questions there. If you wanted to add as we go along, we'll take questions from the audience for the next 15 minutes. And so just keep entering them if you haven't had a chance to yet. I see one here for Jess. When you talk about people getting OAT just to get access to other services, what services are they ultimately seeking?
I think probably just really it's like the unconditional connection, but to have, for some people, they're connecting with a caseworker and it's because they're looking for housing or they need to get their ID or help with some other medical stuff. And for some people, it was to get in to see counseling because it is, for some people, it's over a year wait to access any counseling in our area. We also had a pretty great social worker doing the counseling there, so people were coming out of the woodwork to connect with her.
Thanks so much, Jess. As others are entering into the Q&A pod here, I just wondered, Emma, are you hearing from others about how they've used the Snapshot tool already, or maybe any comments from Tara if you've heard as well?
I've heard that some organizations, especially public health units, those are the ones I've been in, closest contact to, are using it within their health units for situational awareness to, just to have that body of evidence to be able to use towards advocacy efforts. So that's the main way I've heard it used so far. I know even before actually they were finalized, they were getting close to being finalized, but one of the league members on our project group had used it within their community and their networks to just be able to share that this was coming. So I know that so many were interested in being able to see the data presented in this way. So I'm also curious to hear from those listening, if you can ever email me in the future and let me know how you're using it, we'd definitely be interested to know, and I can pass that along to the LDCP group. And I don't know, Tara, if you have any other examples.
I don't have specific examples. So we have, and as Emma mentioned earlier on, I would call it a companion tool, which has a number of other indicators on it, as well as the Public Health Ontario's interactive opioid tool. We gather information on how people have used those indicator tools before, and certainly, various health units, perhaps some of you on this call, as well as Ontario Health and others, do use those data. And we often hear that in terms of local programming, they can be very helpful. And that was part of the goal of creating this dashboard, was realizing that sometimes having all of these distinct tools can be a little bit hard to navigate, and trying to select a combination of indicators that are useful and putting them in one place would be helpful. So I'm hopeful that this will be useful. The link went live today. So I think that I would be asking a lot to have examples of its use in any great degree at this point. But I think that based on what we've learned from the other tools, that it will, I think, hopefully be useful. And I would just also mention, I'll put in the chat the link to the other two tools as well, because what we did, as Emma described so eloquently, was we kind of worked together to figure out what are the right indicators, how can we present this in a way that's really targeted for a lot of people's needs. But we struggled because there are other harm reduction indicators and other outcomes and other ways of slicing and dicing the data that sometimes you might need. So this is kind of the first landing page to go to, I think, for your needs, but also you may find that sometimes if you're looking for another indicator, it might be helpful for you to refer to some of those other tools as well. So I'm just going to put those in the chat in case anybody would find those links useful.
Great, thanks, Tara. Another question here is on sustainability of the tool. So will the data be updated regularly?
I can answer this one. So a decision was made actually at project onset to create a tool that was, for right now. Public health units, I know different organizations across the province are really, taking this time to plan for the future, as a lot of us recover as well from the pandemic response. So the decision was made to do it as like a one-time tool. The LDCP project was also, a 5-month project period with, it's not necessarily built in to continue staffing, for example, to update it. However, having said that, if there was enough demand for it, if health units or organizations across the province wanted us to update it, we may be able to find a way, maybe through a future LDCP, or just the group may decide to, work together and update it in a year or two, or whatever is helpful for your planning cycle. So something to keep in mind.
Thanks, Emma. The next one is, I think it's on a public website, as we've posted in the chat here, but probably more on communicating this with the public. So do you have any thoughts on how to make these tools accessible to the public, and either strategies that you've used or you want to, but maybe haven't been able to yet?
You want me to start that, Emma? I think so. As Emma mentioned, we have an infographic so the report and infographic, if you go to the website, there are buttons for those. They're not live yet. We're just putting the finishing touches on those two documents, but I would guess by the end of the week they will be posted. And we're planning a broad dissemination of the tool and the infographic as a public facing kind of simplified way of communicating these data. And then we do through the ODPRN, which is the group that I lead. We do a lot of different engagement. We have done press releases in the past. I'm not sure we will for this product, but we do distribute it and disseminate it to a number of different places to try and have uptake as broad as possible. We'd also love if people have other ideas of how to disseminate this, or people or other groups outside of public health that we may not have thought of that you might think would benefit from accessing this. Either feel free to share it yourself or let us know, and we're happy to reach out and communicate as well.
Great. So I think that speaks to the follow-up question here about whether the public learning about this is a goal or not, but it sounds like pretty diverse audience that you've attended here, intended. Then from Daphne, just that KFLA will share on the drug strategy website. And also, is there a reason that foils indicator was chosen over pipe use? So maybe Emma, do you want to take that one first, and then the others can respond?
Sure. Yeah, that's such a relevant question. The group had so much discussion actually about that exact thing. There were, there's rationale for both, and so we had a lot of discussion, a lot of back and forth around that specific question around whether to choose foils or whether to choose pipes. And ultimately, what we did was we consulted with the LDCP group, which, as you saw, included a range of different groups there. We consulted with league members, we consulted with staff internally in our public health unit, just to try and get as much information as possible. And although it wasn't actually a super clear favorite, we were limited just by space, unfortunately, in terms of the actual dashboard. So ultimately, the group decided to use foils.
Yeah, maybe Jess can chime in. I think that, one of the things that also led to that decision was that in terms of harm reduction supplies that exist, there are the straight stems, there are paper straws, there are pipes, and then there are foils. And it was felt that, and when we looked at regional variation, there are some regions that had more paper straws and were less straight stems and vice versa, but foils were something that seemed, you can use this for a variety of different ways of smoking and inhaling drugs and preparing drugs. So we felt like it was a little bit more consistent of a measure across regions, as opposed to having to rely on, perhaps one region relies more on straight stems versus the pipes versus the straight straws or the straws. Because if we just chose one of those, because we were restricted with space, it could make it look like one region was not distributing inhalation supplies, when in fact it was because they were, a region that was focusing more on one type of supply versus another. I don't know, Jess, if you want to chime in on that at all.
Just that, I've seen a big switch in my area. People that, when fentanyl first came around, were using the bubble pipes that have switched to foil because it's become so potent and it's easier to use a smaller amount on foil than it is in the pipe.
Great. So the next question here is, how complete are the data sources such as needles and naloxone provided? Are there other sources of needles provided, for example, that might not be included in these data?
So the data originated from a few different sources. The Ontario Harm Reduction Network, which distributes harm reduction supplies through public health, as well as the Needle Exchange Program with data from the Ministry of Health, and the Ontario Naloxone Program from the Ministry of Health, all provided their data to us. And then we used the pharmacy dispensing records to get pharmacy dispensed naloxone. So in terms of publicly funded distribution of harm reduction and naloxone, harm reduction supplies and naloxone, we really expect that we have the vast majority of those supplies. There are a few caveats in terms of, for example, first responders and their naloxone, for example, is not captured in this because it is provided through a slightly different mechanism. But in terms of community distributed harm reduction supplies, we should have covered it with these data. We have pretty much all of the kind of broad publicly funded distribution that exists in the province.
Great, thanks, Tara. Yeah, there was encouragement from one of the attendees that the foil was a good choice for that type of measurement around inhalation. So that's great.
Can I just jump in quickly because I didn't mention, but I feel like I'm shamelessly plugging these other tools, and I want to focus on this being a great tool, but that if you are, for whatever reason, regionally interested in straight stems or the pipes, for example, if you go to the Ontario Opioid Indicator tool, which I put in the chat, you can find all of those harm reduction supplies stratified by health unit as well.
Great. There's a question here from Southwestern, one of the public health units. So seeing on their snapshot that methadone was the second most common drug at the death, and is that because someone was on methadone and also using another substance? So I wonder, maybe Tara, do you want to take that one first, and then others can comment? It's on mute, Tara.
Too many things at once. Yeah, I was just trying to pull it up. So that's, first of all, I would say that's not uncommon. Provincially, usually after fentanyl, methadone is the most commonly found opioid present at death. Sometimes methadone is present with fentanyl or other substances, and sometimes the methadone is present alone. So this dashboard, and honestly, any of the dashboards, don't get into that level of detail because it is quite complicated trying to kind of disentangle all the various substances that people might be using. There are some reports that we have released looking specifically at combinations of substances that people use provincially, not at the regional level. But I will say that certainly with methadone, there's a very large proportion where also fentanyl and possibly other substances directly contribute to death. And then there are certainly some cases where it's methadone alone, but that disaggregation is not present on any of these public dashboards.
Great. And just a question here, which we may only have time for this last one, but looking at the association between the access to harm reduction strategies and the reduction in opioid deaths, and is there a way to look at that association, and can you look at it at a more granular level like the FSA rather than the public health unit level? Maybe I'll leave it up to Tara or Emma, who might want to comment first on that.
We haven't used these data to look specifically at this. I feel like, Kevin, you should lead that study. But I think that there's a lot of opportunity here to do regional level analyses in a way that we can't do because there isn't individual level data. We don't know if somebody specifically got distributed, needles through a needle exchange program or straight stems or foils. So this is all regional level data. We don't have it at the FSA level, though. The health unit level is really the smallest level of geography that we have. But certainly there could still be some work done to try and look at those associations between distribution of harm reduction and outcomes. With one caveat being we did some work on this with naloxone a while back, and the challenge being that sometimes it's a bit of a chicken and the egg question in terms of, there are higher rates of harm or higher rates of substance use, which can be difficult to measure in the data. And so you see more distribution of harm reduction supplies as a result. And so it can sometimes almost look like the harm reduction supplies are causing the harm when in fact it's the harm reduction supplies are responding to the harm. So it can be a little bit hard sometimes to disentangle response to an existing need versus the effectiveness of those programs, because everything is changing so quickly and we have such poor data on prevalence of substance use and what's in the underlying unregulated supply over time.
Great, thanks so much. Well, we are running into our last minute of the session, but we're very grateful to Emma, Tara, and Jess for presenting today and all of this great work that you've done for sharing with all of the public health units. So thanking all of the participants who joined today and the participation in the question and answer period. Just a reminder for people to watch out for a PHO round survey after the session, and you can help us improve our programming for future sessions. And the presentations, you can access past PHO presentations and the upcoming schedules by looking at the PHO website. And we wish everyone a wonderful day, and thanks so much again, everyone.